Hospital and the University of Manchester. This is our third in the series of Part 2 MRCP renal lectures, and today we will be considering miscellaneous nephrological topics. We will be discussing polycystic kidney disease, diabetic nephropathy, renovascular disease, reflux nephropathy, myeloma in the kidney, and renal tubular acidosis. So the first question concerns an 18-year-old man who is reviewed in a renal clinic having been referred because of hematuria. His brother died at a young age from a subarachnoid hemorrhage, and his father died with complications after renal transplantation. On examination, his blood pressure is 152/89, his heart sounds are normal and chest is clear. On abdominal examination, an irregular left-sided flank mass is palpable. The basic investigations show normal hematology, slightly impaired renal function with a creatinine of 135 micromoles per litre. Urinalysis reveals 1+ hematuria but no proteinuria. So the question is, if he is managed optimally, within which one of the following time periods is he most likely to require renal replacement therapy? So this case concerns autosomal dominant polycystic kidney disease. This is given away by several features in the clinical history. Firstly, the brother who died of a subarachnoid hemorrhage. Secondly, more evidence of familial disease with his father having renal failure. And thirdly, the palpable mass in the flank, which of course would be an enlarged kidney. Now this patient has already evidence of minor deterioration in renal function. Provided that he is optimally managed, one would expect him to take at least 10 years before he progresses to end-stage renal disease. These slides show features of polycystic kidney disease. The top left shows a massive surgical specimen of a polycystic kidney measuring 30 centimeters in length and weighing almost 2 kilograms. You can see that the cysts are of variable size, some containing blood. The X-ray on the right is an old X-ray of an IVU in a polycystic kidney patient. You can see the markedly enlarged pelvic calyceal system of each kidney, measuring probably 10 centimeters or the length of 2.5 vertebrae. And you can see the indentations into that pelvic calyceal system, which becomes spidery and thin because of the cysts abutting against it. So considering autosomal dominant polycystic kidney disease, there are two main types that we recognize. PKD1 has a genetic abnormality on chromosome 16, and this occurs for the vast majority of cases of AD-PKD, perhaps 86%. These patients have a mean age of developing end-stage renal disease of 57 years. The PKD2 gene is located on chromosome 4, and this accounts for approximately 10% of patients. These patients tend to present later, perhaps a decade later, with end-stage renal disease. Now, we're often asked the question, if there is a son or daughter, brother or sister of a patient with polycystic kidney disease, and they have an ultrasound scan, and this scan is negative, is it still possible that they can develop PKD in the future? The answer is, if the person is 20 years of age and they do not have cysts visible on ultrasound scanning, then you can be 90% confident that they will not get PKD in the future. If they are 30 years of age and no cysts are seen at ultrasound, then you can be 99% sure that they will not develop the condition. What are the associations of AD-PKD? Well, liver cysts can occur in 70% of patients, pancreatic cysts in 10%, 5% of patients have berryaneurysms, and in a proportion of these, but certainly not all, these can rupture and bleed and lead to subarachnoid hemorrhage, as was the case for this gentleman's brother. Mitral valve prolapse is a relatively common valvular abnormality. and some patients rarely get hepatic fibrosis. In the second question, we consider a type 2 diabetic man, 65 years old, who has had diabetes for 10 years and has been diet controlled for the initial 4 years, and since that time, oral hypoglycemic therapy in the form of gliclazide and metformin. Unfortunately, he's been missing from follow-up appointments over the few years prior to this consultation. His blood pressure is 154/74. He has no evidence of peripheral neuropathy. And his investigations from the previous clinic are as follows. He has reasonably good glycemic control, HbA1c 6.3%, and on dipstick urinalysis, there's no proteinuria or glycosuria. His creatinine is slightly increased at 98 micromoles per litre, but a urinary ACR is 18 milligrams per millimole. So the question is, which is the management step most likely to improve his overall prognosis with respect to renal and other complications? So this gentleman has evidence of diabetic microalbuminuria, which is the early stage of diabetic nephropathy. I'll define the range for microalbuminuria in a few moments. Now, in terms of the optimum treatment for this condition, from the list of possibilities we were given, the evidence base would suggest that angiotensin receptor blockers would be the most appropriate. There is no doubt that many diabetologists and nephrologists would also consider A as a possible treatment, so ACE inhibitors. However, the randomized controlled trials looking at early diabetic nephropathy and type 2 diabetes have largely been done with the ARBs, notably irbesartan and losartan, and have shown benefit, and hence the rationale for choosing E. This slide shows two things really. Top left, it shows a diabetic nephropathy, quite an exudative picture, widespread throughout the retina. And on the bottom right, we can see the pathognomonic renal lesion at biopsy of diabetic nephropathy, the Kimmel-Steele-Wilson nodule. However, in the majority of cases of diabetic nephropathy that are biopsied, this will not be shown. More often we see a widespread increase in sort of pink staining within the mesangial areas as the basement membranes of the glomerular capillaries are thickened with glycosylated material. This slide shows a schema of the development of diabetic nephropathy in type 1 diabetes. The left axis is GFR, the right is proteinuria, and the horizontal axis is time after onset of diabetes. And you'll see that in a typical type 1 diabetic, of which 40% will develop nephropathy, at around 10 to 12 years after onset of diabetes, they develop hyperfiltration as evidenced by an increase in GFR, and concomitant with that, microalbuminuria. Now, if these patients are treated during that phase, the microalbuminuria can be halted and sometimes reversed, but in 60 to 70% of patients, even if treated, there can be progression to persistent dipstick positive proteinuria, and in that phase we then start to see declining GFR. As I mentioned, it's important to understand our proteinuria testing systems. Normally we would each be allowed to pass around 150 milligrams per day of total protein, of which only about 15 milligrams should be albumin. As you can see, the definition of microalbuminuria is an excretion of albumin of 25 to 250 milligrams per day, which associates with a urinary ACR of 2.5 to 25 milligrams per millimole. Now, remember that in a typical urine output for a typical individual, there will be about 10 millimoles of creatinine each day, and hence if you multiply the urinary ACR by 10, that gives you a figure of the total excretion of albumin each day. So, for example, a urinary ACR of 15 would be 150 milligrams of albumin per day. Proteinuria of greater than a gram per 24 hours often requires renal biopsy, except where the diagnosis of diabetic nephropathy is clarified, such as patients with progressive nephropathy and associated retinopathy. This is a continuum showing the outcome of patients as followed in the UK PDS study, and the point of showing you this slide is to show the increasing risk of mortality associated with more significant stages of diabetic nephropathy. So, for example, a diabetic without nephropathy has a 2% annual chance of progressing through to developing microalbuminuria and an annual mortality of 1.4%. In the microalbuminuric phase, they have approximately a 3% risk of developing macroproteinuria, dipstick positive, that is, each year, and a similar risk of death. Whereas when they get significant proteinuria, the mortality rate increases further to about 4.5%, and when the patients are on dialysis, the annual mortality can be over 20%. I mentioned the studies that have investigated angiotensin receptor blockade in slowing progression in diabetic nephropathy. This was one such study, the IDNT study, which compared irbesartan versus amlodipine versus placebo in patients with advanced diabetic nephropathy. On average, they had almost a gram of proteinuria per 24 hours and creatinines up to 250 micromoles per litre. And this study showed that there was a 20% reduction in the combined endpoint of mortality, doubling of creatinine, or progression to end-stage renal failure in the irbesartan treated group of patients compared to the other two. And this was for a similar degree of blood pressure lowering in all three groups. And as you can see, there was a significant decrease in proteinuria in the irbesartan treated patients compared to the other two groups for a similar degree of blood pressure lowering. So let's talk about diabetic nephropathy. This is the commonest cause of CKD in the Western world. As mentioned, there's an annual mortality of about 1% in diabetics without nephropathy, and this multiplies several times in patients with early nephropathy, where you can see the 4-year mortality can be as high as 28%. When patients develop end-stage renal disease with diabetes, they're at very high risk, and the overall annual mortality can be 15%. Indeed, the patients who remain on dialysis have a 5-year survival of only 20%, whereas if they are transplanted, then they have a 5-year survival that is more than 2.5 times that, at 50%. So let's consider question 3. A 72-year-old man with a history of hypertension presents to the emergency department in extremis. He awoke in the early hours of the morning with severe shortness of breath, as if he was going to gasp his last breath. You understand his GP had commenced him on ramipril a short time ago. On examination, his blood pressure was 175/85, his pulse was 100 per minute, and he was in left ventricular failure. He's treated with a nitrate infusion and furosemide, and there is some improvement. His results show a normal hematological picture. His potassium was 4.5 millimoles per litre, but creatinine was 204 micromoles per litre, having previously been 134 micromoles per litre 1 month earlier. An echocardiogram showed left ventricular hypertrophy only. So which one of the following is the most likely cause of this person's presentation with pulmonary edema? Clearly, this is a person who presented with acute, sudden onset pulmonary edema. We sometimes call that flash pulmonary edema. And you'll notice that there had been a significant increase in creatinine following the use of an ACE inhibitor. So by far the most sensible choice here would be renal artery stenosis, which is E. Now these slides show the commoner forms of renovascular disease that we encounter in the Western world. 90% of all of our cases are atherosclerotic renovascular disease, as shown on the left, whereas fibromuscular disease, a disease of younger people, particularly women in their 20s and 30s, accounts for perhaps 10% of all cases of renovascular disease. Atherosclerotic renovascular disease is commonly associated with other cardiovascular comorbidities. So up to 15% of them will have coronary artery disease, up to 30% of the elderly patients, say aged over 70 with renovascular disease, will have congestive cardiac failure, 40% might have peripheral vascular disease, 30% aortic aneurysms, and around 10% will have a history of stroke. What are the possible clinical presentations of renovascular disease? Well, it's been associated with perhaps 2% of all cases of hypertension, but I think many of us would be skeptical whether the renovascular disease is the cause of the hypertension in the vast majority of those, more likely an association. Patients can present with acute kidney injury and flash pulmonary edema, as we saw in this case. Other patients commonly present with CKD and are frequently detected as an incidental finding. For example, when undertaking coronary angiography, if a flush aortogram is performed at the same time, then we might find renal artery stenosis that could be just incidental. And some patients, of course, are investigated for intolerance of renin-angiotensin blockade. Now, flash pulmonary edema is a relatively uncommon presentation of renovascular disease. By far the most frequently method for revascularizing atheromatous renovascular disease is to perform angioplasty and stenting, as evidenced in this picture, where we can see the mesh wire of a stent in the ostial region of the left renal artery. Now, we've had a recent large randomized control trial published. This is called Astral. It was published in the New England Journal of Medicine in November 2009. And this investigated 806 patients, half of which underwent renal revascularization with stenting and the other half medical therapy. The primary outcome measure was renal functional change over time. And as can be seen in this figure, there was no significant difference between the two groups followed out to 5 years in terms of the primary outcome. In other words, renal revascularization did not improve renal functional outcome compared to medical therapy alone. And as you can see, the two groups were identical in terms of their blood pressure control. This is systolic blood pressure. At 12 months, there was a fall of systolic blood pressure of about 5 millimeters of mercury, but no difference between the groups. And overall survival out to 5 years was identical, two overlapping lines, with a mortality of around 8% per year in both groups. So Astral has certainly helped us shape our understanding of when we should perform renal revascularization for atherosclerotic renovascular disease. And the consensus would be now that if a patient presents with severe or dialysis-dependent AKI, or very severe hypertension, perhaps with systolic blood pressures in excess of 180 millimeters of mercury and on sort of 4 or 5 drugs, patients who would benefit from renin-angiotensin blockade, say for example for heart disease, but who are intolerant of them without developing significant rises in creatinine, those patients with flash pulmonary edema like occurring in the case, and perhaps patients with rapidly deteriorating renal function, these would all be categories that clinicians would consider performing revascularization for. In those more stable patients with CKD, fairly severe hypertension, then we would say that there is no indication to perform renal revascularization because there is a downside, and that is risk of major complications from the procedure. There's also another interesting group of patients who can be shown to have functionally significant renal artery stenosis, and these patients might have larger volumes of kidney for a given GFR, and currently there are studies underway trying to determine whether these can be found readily by our usual clinical investigations. The fourth question concerns a 28-year-old lady who's reviewed in the clinic because of intermittent left loin pain. She's been generally well, but occasionally feels nauseated and off her food, with intermittent burning and stinging of the urine. Examination reveals a BMI of 25 and a blood pressure of 145/82. Her results show a creatinine elevated at 95 micromoles per litre and urinalysis showing 1+ blood and protein. An ultrasound of the renal tract reveals a significant abnormality with a dilated left ureter down to bladder level and a smaller left kidney with an irregular outline. So which one of the following is the most likely cause of this patient's clinical picture? The answer to this is, of course, chronic ureteric reflux. This patient has got a small scarred kidney, which we would term as pyelonephritic, and she also has a dilated ureter all the way down to the level of the bladder, in keeping with chronic reflux. This illustration shows a patient with bladder dysfunction, actually a patient with spina bifida. You can see the markedly distended bladder, abnormally shaped, and the bilateral reflux with nephropathy on both sides, gross dilatation of the pelvic calyceal systems. This figure illustrates the different grades of reflux from very mild up the ureter only, which is grade 1, to grade 5, which is similar to the illustration I just showed you, with scarring and gross mega ureter. So what is reflux nephropathy? Well, we know that vesico-ureteric reflux is common, and that occurs in about 1% of newborn children. However, reflux nephropathy is defined as vesico-ureteric reflux plus kidney damage. It is the commonest cause of chronic pyelonephritis, which really is a description of a radiological or post-mortem anatomy picture of scarring of the kidney. When scarring occurs, it develops in early childhood in reflux nephropathy, usually in the first 5 or 6 years of life. It's important to understand that those children who present with a UTI, 30% of them will have vesico-ureteric reflux, and 10% of them will have signs of nephropathy already. So that would be a scar seen on ultrasound, or even maybe with a DMSA scan. 5% of women with urinary tract infections also have reflux nephropathy. There is a genetic predilection here, and 25% of first-degree relatives of patients with reflux will themselves develop vesico-ureteric reflux, and hence children of a mother who has reflux should be screened for the condition. What about the treatment of vesico-ureteric reflux? In children, the aim is to prevent scarring, because, as I mentioned, scarring more or less only occurs in childhood. There is no indication to operate on adults who have reflux in order to prevent scarring. We occasionally do it to control pain in patients who get intermittent severe loin pain. The milder grades of reflux, notably 1 to 3, often resolve spontaneously, and so antibiotic prophylaxis is given for children who have grade 2 or worse reflux, and they would take these agents for up to maybe 5 or 6 years to prevent scars developing. For those children with grade 4 or 5 reflux, the options would be either antibiotics or some form of anti-reflux surgery. Otherwise, for reflux nephropathy, blood pressure control is important, and as I've mentioned many times before, renin-angiotensin blockade would be the drugs of choice in these individuals who've got risk of progressive CKD and proteinuria. Our fifth question concerns a 70-year-old male presenting with fever, productive cough and dyspnea of 3 days duration. He's been gradually unwell for 4 months with lower back pain, lethargy, reduced appetite, and he's lost 2 kilograms in weight. He's hypertensive on atenolol 50 milligrams daily, and he smokes 15 cigarettes daily. On examination, he was febrile with a temperature of 38 centigrade. His pulse was 115 per minute, and blood pressure low at 105/55. He appeared pale with pitting edema of both legs, but he had no palpable lymph nodes. When we look at his results, we can see that he has a right lower lobe consolidation as evidenced by chest x-ray. He's got markedly abnormal hematology with a hemoglobin of 7.5 grams per litre, a white count of 19, platelets low at 89, and an ESR elevated at 115 millimeters per hour. He's got marked renal failure with a creatinine of 440 micromoles per litre, a urea of 21, and note his total protein is high at 90 grams per litre, and as the albumin level was only 28 grams per litre, this must mean that he's got a very elevated globulin level of 62 grams per litre. His calcium is also high at 3.2 millimoles per litre, and he has blood and protein in his urine, but no growth on an MSU. So which one of the following is the underlying diagnosis that best fits the clinical picture and investigations? So clearly the best answer here is multiple myeloma. The case describes an elderly person who has severe hematological abnormalities with anemia, low platelets and high white count, a very high ESR, hypercalcemia, mild proteinuria and significant renal impairment. There is also hyperglobulinemia, which of course would be in keeping with the myeloma. This slide shows the picture of myeloma cast nephropathy, where you can see these very dense spiculated crystals blocking the renal tubules. So, 50% of myeloma patients will develop some form of kidney involvement, and this usually presents as acute kidney injury. In some of these patients, there is reversibility of the renal failure, especially the cases associated with infection, hypovolemia and nephrotoxin damage, and also hypercalcemia. 10% of patients with AKI will need dialysis, and these patients usually have cast nephropathy, as evidenced by the previous slide. Some patients with myeloma can present with CKD, however, and in these cases we find proteinuria, which can be at nephrotic range, and on renal biopsy we might find amyloidosis. Other possible cause of CKD is chronic interstitial nephritis. What about the treatment and prognosis of myeloma kidney? Rehydration and supportive therapy would be essential, as in any case of AKI, but particularly relevant here. Now, there have been some trials undertaken to assess whether plasma exchange is of benefit in cast nephropathy, and we're still awaiting definitive results. Younger patients and those with low tumour bulk will be treated with chemotherapy in the form of VAD regimes, and then hopefully progressing to possible autologous stem cell bone marrow transplants. In the older patients and perhaps those with a higher tumour bulk, other treatments include dexamethasone, melphalan and thalidomide. In those patients who present with cast nephropathy causing AKI, then recovery of renal function occurs in only 20% of patients. Note that the overall survival is poor in patients who have myeloma and renal disease, the 1-year survival being less than 50% for those patients who need dialysis. So our sixth question concerns a 23-year-old motor mechanic admitted to hospital with severe left loin pain and vomiting. Prior to this, he described a 5-week history of worsening generalized weakness and anorexia. He was previously well and on no regular medication. On examination, he was in obvious discomfort and hyperventilating. There was tenderness and guarding in the left renal angle, but no other significant findings. His investigation showed normal hematology, a low potassium of 2.9 millimoles per litre, a creatinine elevated at 120 micromoles per litre, a significantly low bicarbonate of 13 millimoles per litre, and a chloride elevated at 120 millimoles per litre. He had a phosphate that was normal at 0.9 millimoles per litre, and a uric acid of 0.32 millimoles per litre. His arterial blood gases confirmed acidosis with a pH of 7.21. The PCO2 was reduced at 2.8 kPa. Urinalysis showed a pH of 6.3 and 2+ of blood. An abdominal X-ray revealed speckled calcification in the left and upper right quadrants. So the question is, which one of the following is most likely to be the diagnosis? So the correct answer here is A, type 1 or distal renal tubular acidosis. And this answer is based upon the fact that this patient had a metabolic acidosis with a normal anion gap. So when we're considering patients with a metabolic acidosis, it's important to look at the anion gap. These figures show the normal constituents of plasma. So the left-hand panel shows the cations, sodium and potassium, but in addition you can see calcium and magnesium, and you can see the anions, which largely are composed of chloride and bicarbonate. Bicarbonate, of course, normal range about 22 to 28 millimoles per litre. In the situation of acidosis, we have two types. We've got the normal anion gap acidosis, where bicarbonate, of course, is low, and that defines the acidosis, and we have an increase in chloride compensatorily, so we call this a hyperchloremic acidosis. The anion gap remaining at around about 12 to 15 millimoles per litre. In the situation of a wide gap acidosis, which is associated with exogenous acids in plasma, the bicarbonate again is low at say 15 millimoles per litre here, but it's the anion gap which reflects the exogenous acid, and that's widened to 25 millimoles per litre here, and the chloride has not increased. So to summarise, the anion gap is the measured cations, which we simplify as sodium plus potassium, take away the two commoner measured anions, which are chloride and bicarbonate. And if the gap is within the normal range, then this is called a normal gap acidosis, and the conditions associated with that are renal tubular acidosis, diarrhea, because in that condition, of course, there is excretion of bicarbonate, treatment of glaucoma with acetazolamide, and some cases of ureteric diversion, so-called ureterosigmoidostomy. These operations were performed to divert urinary tracts before we started to use ileal conduits. In terms of etiology of the wide gap acidoses, as I mentioned before, these are exogenous acids in plasma that we would not normally measure, such as those found in uremia, the organic acids in liver failure, diabetic ketoacids, salicylic acid in salicylate poisoning, and also in ethanol and methanol poisoning we have acetic acid and formic acid respectively. Then of course lactic acidosis, ethylene glycol poisoning as well. Now this schema of the nephron shows all of the resorptive sites throughout the renal tubule. You can see that in the proximal tubule to the left there is a major degree of reabsorption of many different substances. So this is where bicarbonate is reabsorbed, and of course it's failure of this mechanism in type 2 renal tubular acidosis that leads to the proximal form of RTA. And you can now see why with type 2 renal tubular acidosis there can be multiple reabsorptive defects, such as poor resorption of phosphate and glucose and amino acids as well. And you've heard of the Fanconi syndrome, which can be associated with proximal RTA. Of course, distal RTA is associated with the failure of acidification of the distal urine by ammonia. This table shows the difference between type 1 and type 2 renal tubular acidosis. I've already described the defect that leads to the acidosis, but note that in type 1 or distal RTA, the urine pH tends to be more alkaline than in type 2, and that's because the degree of acidosis is more severe as a general rule, and that's manifest by a lower level of bicarbonate in distal type 1 RTA. This is because there is a threshold effect in type 2 RTA, and that means that when the bicarbonate drops to a level as low as maybe 14 millimoles per litre, then the proximal tubule starts to reabsorb bicarbonate again, which protects against increasing severity of the acidosis. Now, as calcium salts are more soluble in acid urine, this explains why type 1 RTA is associated with nephrocalcinosis and calculi. That is because they have a more alkaline urine, because the acidosis is more severe in that condition. Whereas it's type 2 RTA that's associated with osteomalacia and rickets, notably because of the phosphaturia that might accompany the loss of bicarbonate because of failed reabsorption. So if you recall our case that we were discussing, this patient had a fairly severe acidosis with a pH of 7.2. They also had bilateral nephrocalcinosis and a history suggestive of a renal calculus. So this would be compatible with type 1 or distal RTA. Finally, let's consider the causes of the different types of renal tubular acidosis. Type 1 is fairly common because it can be associated with any form of tubulointerstitial disease within the kidney, such as chronic pyelonephritis. You can see it with obstructive uropathy. It can be primary as a genetic abnormality. It can be secondary to autoimmune diseases like lupus and Sjögren's syndrome. And also, distal RTA can be associated with medullary sponge kidney and hypercalcemia. Drugs and toxins, most notably lithium and amphotericin and toluene, can be associated with type 1 RTA as well. When we consider the causes of proximal or type 2 RTA, this is less common than distal RTA. Idiopathic causes probably predominate. Proximal RTA can also be associated with Fanconi syndrome, with multiple reabsorptive defects in the proximal tubule, notably in Wilson's disease, cystinosis, Sjögren's syndrome, again, multiple myeloma. And then it can be associated with drugs and toxins, for example, time-expired tetracyclines, lead and mercury poisoning, acetazolamide, and sulfonamides. So that concludes